A very good morning to all of you. First of all, I will like to wish all of you Happy World Anesthesia Day. As you have seen on Facebook, on YouTube, AORA is coming up with various new initiatives. We have case of the week, we have uh, article reviews, we have block of the month, and now there is a new initiative from AORA. That is focus video of the month. So every month we will come with new video by new expert, and we will try to learn about point of care ultrasound. So today we will discuss about EFAST. FAST is basically focus assessment by sonography in trauma patient, and EFAST is extended FAST. So we'll learn what it is and how it is useful. Uh, Before I start my presentation, a disclaimer is schematic diagram used in presentation are borrowed from some of the articles and Google, and some of them are prepared by Dr. Amrita Rath. I am thankful to all of them. Uh, we will start with a case. 34-year male patient comes to emergency with road traffic accident. Patient is conscious and oriented, but slowly deteriorating. Patient is complaining of pain in abdomen. Pulse is 130 per minute. Initially, BP is 90 by 60, but slowly BP is going down and pulse is increasing. So in such cases, we will suspect some blunt abdominal trauma. So we can diagnose it with three techniques. First is diagnostic peritoneal lavage. Second is CT scan, and third is ultrasound fast examination. So first, we will discuss about diagnostic peritoneal lavage. There are some advantages and some disadvantages. Here we puncture the peritoneum and aspirate for the blood. If we find the blood, it is positive peritoneum diagnostic peritoneum lavage, and we will go for laparotomy. So advantages are it is very sensitive for identifying intraperitoneal blood. It can be done at the bedside, and it can be done in 10 to 15 minutes. But at the same time, it is overtly sensitive and it may result in too high laparotomy rate. Even small amount of blood, we will get it, and patient will have negative laparotomy. It is invasive, so chances of infections are there. It is difficult in pregnancy or with many prior surgery, and it cannot be repeated. Once we do it, that is done, we cannot repeat it. It is difficult to repeat it. CT scan, it is a gold standard technique. It identifies specific organ injury. It is good for hollow viscous and retroperitoneal injury, which cannot be detected by fast. It is highly sensitive and specific, but disadvantage is expensive equipment that is not available everywhere in small hospitals. It takes 30 to 60 minutes to complete the study. Sometimes you have to inject the dyes, you have to ship to the patient, and sometimes it will take 30 to 60 minutes. If it is in-house, it may takes little less time. It is only for stable patient. You cannot move the unstable patient to CT scan unit, and it is not for the pregnant patient because high radiation exposure. At the same time, eFast is the modality which can be helpful and overcome all these disadvantages. eFast is basically, as I said, extended focus assessment with sonography in trauma. It is a bedside ultrasonographic protocol designed to detect peritoneal fluid, pericardial fluid, pneumothorax, and or hemothorax in trauma patient. It was started in early 1970s, but it was not very popular. It became popular in US in 80s, and since last 40 years, it has become a part of routine emergency examination. And in fact, it is part of SELS nowadays. So advantages are it can be performed within 5 minutes at the bedside and even faster if you are expert. It is non-invasive. You can repeat exam when patient's condition deteriorate. You can repeat the examination, or sometimes initially fast is negative, but patient is deteriorating. So in that case, you can repeat the examination. Sensitivity and specificity for pre-fluid equal to diagnostic peritoneal lavage and CT scan, but disadvantage is it is operator dependent. If it is if operator is not skilled enough, there are chances that we will miss the things. It may not identify specific organ injury. It is poor for hollow viscous for retroperitoneal injury, and in patients with obesity, subcutaneous emphysema, that will interfere in the examination. It is not useful. So, what is the principle of FAST? It detects free intraperitoneal fluid. So, basically, we want to detect the intraperitoneal fluid. Mostly, it is the blood in trauma patient, but sometimes it can be something else. So, blood and fluid pools in the dependent area. So, which are the dependent area? In pelvis, pelvis is the most dependent area where you can look for the blood, and hepatorenal fossa is the most dependent area in the supra mesocolic region. So these are the area where you can look for the fluid. So pelvic and supramesocolic area communicate with areas communicate through proinocolic ligament that prevents the blood flow. So there is a ligament in between these two which prevents the blood flow. So, sometimes if you find the blood in upper area, sometimes it is not there in the pelvic area. Sometimes it is in the both area also. So liver spleen injury, it represents two-thirds of cases of blunt abdominal pain, trauma. So when there is blunt abdominal trauma, there are chances that there is liver and spleen injury. But as I said, intraperitoneal fluid may be blood, pre-existing ascites, urine, or intestinal contents. So we cannot differentiate with fast, but you can detect it. So that is the limitation of the past, and another limitation are US is relatively insensitive for detecting the traumatic abdominal organ injury. So which organ is specifically injured, it is difficult to diagnose. Fluid may pool at variable rates. Sometimes rate of the collection is slow. Minimum volume for US detection is like in right upper quadrant view, it is 600 ml, pelvis it is 200 ml, roughly 200 ml. So there is some minimal amount of fluid which is required to detect on ultrasound. But up to 600 ml, we don't need to explore the patient because till that patient is stable, and we can think of conservative measure. We have to take multiple views at multiple sites. Serial examination is required if there is a change in clinical picture, as I said, and it is operator dependent. So objective is to detect the intra-abdominal free fluid, detection of the pericardial fluid, and detection of hemothorax and pneumothorax. So there are mainly 5 views. Right upper quadrant view, that is RUQ, LUQ is left upper quadrant view, suprapubic view, subxiphoid view, and the thoracic views. So we have to examine it at these area, right upper quadrant, left upper quadrant, suprapubic, subxiphoid, and both sides for the lung. So in right upper quadrant view, what we evaluate? We evaluate Morrison's pouch, that is a potential space between liver and right kidney, where you will find the blood. Caudal edge of the liver or the liver tip, and space between liver and the diaphragm. So these are the area where blood can collect, and we are examining those area. Left upper quadrant view, we examine the perisplenic space, including the space between spleen and the diaphragm as well as the splenorenal recess. There is a potential space between spleen and the kidney. In pelvic view, there are two views, that is transverse and longitudinal. We assess rectovesicular space in the male, and vesico-uterine pouch and retrouterine pouch, that is pouch of the class in female. In subcostal cardiac view, we look for the pericardial space, and we look for the hemopericardium. So in right upper quadrant view, probe is placed at the mid-axillary line between 8th and 11th rib. Probe should be placed in an oblique angle. Sometimes you can keep it vertical also, but if you place it little oblique, in the intercostal space, rib shadow will not come in between, but you have to manipulate the probe to see the best picture with probe marker pointing cephalad and towards the right posterior axilla. The resulting image should include the liver, right kidney, and the right kidney interface, and the super kidney and the diaphragm interface. So we are looking for subdiaphragmatic collection and collection in the Morrison's pouch. So what we see when we put the probe, we see the liver shadow, we see the kidney, we see the space between the liver and the kidney, and we see the space between diaphragm and the liver. We see the spine also. Up to this level, up to diaphragm, you will see the spine, but above the diaphragm, you won't see the spine because air will interfere in the ultrasound shadow. But if patient is hemothorax, then you can see the spine. So that is called spine sign. So if you see the spine above the diaphragm, then there are chances of hemothorax or some collection in the pleural cavity. So this is the view that is called right upper quadrant view. So here you can see this is the liver, this is the kidney, this is a space between liver and kidney, and this is the tip of the liver. These are the shadow of the spine. So you can see this is the diaphragm. So you can see the shadow up to the spine up to the diaphragm. So here you will see this is the kidney, this is the space, these are the shadows of the rib, this is the diaphragm. So in this area, we are looking for the any fluid collection when in the trauma patient. In left upper quadrant view, we place the probe at the posterior axial line at the 6th to 9th rib. Here we are going a little bit careful. This is often described as the operator placing the knuckles on the bed. So you have to put the knuckles on the bed so that you can go as posterior as possible. The ultrasound view should contain diaphragm, spleen, and the left kidney. So here you can see this is the spleen, this is the kidney, and this is the diaphragm, and this is the left lung. Again, spine is also seen. So this is the picture, and we are looking for the fluid here or here. So in this video, we'll see this is the kidney, this is the spleen. We are looking in this for the space. These are the spine shadow, and this is the diaphragm. So we can see the spine shadow up to the diaphragm, not beyond that. So this is the view, left quadrant view. So once we get this, we will move to the suprapubic view. There are two different planes. To obtain the longitudinal view, the probe is placed 2 centimeters superior to the symphysis pubis, and it is directed little bit caudally at midline with probe marker pointing towards the patient's head or cephalad. So what we see the bladder. This is in patient, female patient. We see the uterus and we see the rectum. So these are the two potential spaces between bladder and uterus. And this is the another space that is uterus between uterus and the rectum. So where we can see the blood. But in this view, there is a caveat. If bladder is full, it will provide a better echogenicity beyond that. So if bladder is full, you can see this collection very well. This view should be taken before putting a catheter so that we can see in a better way. Here you can detect the fluid with less amount of the fluid, but you have to be careful, especially in the female patient, because there is some amount of physiological fluid in this area. So be careful about it. If you are not getting the fluid, you can give reverse Tredelenburg position or head up position so that fluid comes towards this area and you can detect it easily. Same way in the right upper quadrant view and left upper quadrant view, you can give Tredelenburg position so that you can detect the fluid easily. So with less amount of the blood, you can detect it. So in this is in the main, that is this is again female. This is the retrouterine pouch or a pouch of Douglas, or this is the area where fluid get collected. So here you can see this is the bladder, and you can see the catheter coming in. So this is in the male patient, so you will find a fluid somewhere here. So you have to tilt the probe. You have to manipulate the probe to see the blood collection in this area. In subxiphoid view, it is obtained by placing the probe just inferior to the xiphoid and directing toward the patient's head. The probe marker should be aiming toward the patient's right side. It is important to flatten the probe down to so that it is roughly flat on the abdomen. So you have to press the probe on the abdomen. To do this, probe is held with the pincer grasp so that operator hand does not interfere with flattening. So it is hold like this so that it doesn't come in between. And you can ask the patient to flex the knee so that the abdomen becomes a little bit relaxed. So what you see is you will see the liver shadow, you will see the heart. This is the right atrium, right ventricle, left ventricle, and left atrium. So it is reverse to the what you see in the four chamber view. So here you can see this is the liver, this is the right ventricle, right atrium, left ventricle. So you are looking in this area. This is the pericardium. So if there is a collection in this area, it will give a it will give a black shadow outside this hyperechoic area, and there will be two shadow. So it can be easily detected. We will see in the future slides. So here you can see the heart. You can even evaluate the contractibility of heart. If you find any blood here in trauma patient, there are chances of tamponade. So you should drain it immediately to prevent sudden cardiac collapse. At the same time, sometimes if you don't get proper image there, you can go for parasternal long axis view. This is parasternal long axis view. We'll see. You can see this is the left ventricle. This is the left. Here, this is the left ventricle, this is left atrium, mitral valve, this is right ventricle. So if there is any collection here, this is a patient with little bit of left ventricular hypertrophy, and somewhere here will be the aorta. So if any fluid collection is here, that is pericardial effusion. But if you find any fluid below the aorta, this is abdominal aorta. So if you find the collection here below the aorta, then there are chances that it is a pleural effusion. So you can differentiate between pleural effusion and pericardial effusion with this. Here you can see this is the aorta. By that you can differentiate between pleural effusion and the pericardial effusion. Last view is the thoracic view. Here we will see for the pleura and the ribs. There is a sign called lung sliding. If it is present, pneumothorax is ruled out. Uh, hemo, uh, uh, mm, mm, Hemothorax you can easily detect while doing right upper quadrant view and left upper quadrant view along with the hemoperitoneum. But for pneumothorax, if you find this is the lung movement. These are the two pleura, that is visceral and parietal pleura sliding with each other. So if you find that pneumothorax is ruled out, but if you confirm the pneumothorax, you have to go for lung point and other signs. But it is again another topic, so we'll not go into the details. So once you find it, it is ruled out. So these are some pathological image. You can see this is the liver, this is the kidney, and there is a collection between a liver and the kidney. So this is positive EFAST. Again, this is the spleen and the kidney, but this is not the blood collection. It is mostly a bowel shadow. So you have to be careful that you don't consider bowel shadow as a hemoperitoneum. Again, this is the spleen and kidney, and you can see subdiaphragmatic collection in these patients. This is the uh, pelvic view where you can see the collection between bladder and the uterus. So this is the collection in this area. Again, this is the hemopericardium. This is the heart. Uh, and if you find right ventricular and right atrial collapse while the systole, and then there are chances that the patient is going into the cardiac tamponade. So in that case, you have to drain it immediately. Again, this is the positive past along with the pleural, if pleural hemothorax or pleural effusion. Again, this is a video where you will see this is the positive past. You can see there is a collection, big collection in between this. If it is 0.5 centimeter, if this strip is 0.5 centimeter, this is the between spleen and the kidney. Then it is 500 ml. If it is 1 centimeter, then it is roughly 1,000. So that is rough estimation. So some real life scenario, we had a patient with a head injury who was taken for craniotomy, but when we induced the patient, there was hypotension and it was not correlating with the induction. So we put the probe on the abdomen and we found hemoperitoneum. So immediately we called the surgeon and we went for the laparotomy and we found the liver trauma. Same way, a urologist was doing TURBT. Patient had sudden complaint of discomfort and bradycardia. We looked for pubic view and we found the fluid inside the peritoneal cavity, and that was because of bladder perforation. Another example, a patient was posted for ventricular pleural shunt because of failure of ventricular peritoneal shunt uh, in that patient. So after putting the shunt in the pleural cavity, we inflated the lung properly, so there were no chances of pneumothorax. But when we extubated the patient had decrease in saturation. So we thought of pneumothorax. Immediately we looked for the pneumothorax with lung ultrasound, and when we found pneumothorax, we simply put the needle and it was drained and patient became comfortable. So you can use these things in the inside your operation theater, and you can provide better care to the patient, and you can actually become perioperative physician if you learn the fast point of care ultrasound. But there are some pitfall and limitation, like it has got excellent specificity but low sensitivity. So if you get the fluid, positive predictive value is excellent, like up to 95 to 100%, but it has got low sensitivity. So if you don't find fluid, it doesn't mean that there is no hemoperitoneum, because you require 500 600 ml of fluid inside the peritoneal cavity to for a positive right upper quadrant view. So you have to go for serial examination. Brane et al. Found that the mean detectable volume needed for visual and RUQ via assessment of Morrison's pouch was 619 ml. So it is 600 ml roughly. And von Kuzenberg and Wegner found that between 129 and 157 ml could be detected in the pelvis. But again, pelvic view are little difficult, so sometimes you miss it. So to improve the sensitivity, you can use the position. As I said, in right upper quadrant view, you can give head low position or treadle onward position, and in pelvic view, you can give head up position. You have to look for full bladder. You don't catheterize the patient till examination is over, because bladder will help to see the pelvic view better. Serial examination is recommended if patient is deteriorating, because there are chances that there is hemoperitoneum which is not detected earlier. And experienced examiner is important, because a beginner may sometimes miss the hemoperitoneum. There are some chances of false positive, like pleural effusion. It looks like hemothorax. So if patient has pre-existing pleural effusion, it is missed. Pre-existing peritoneal fluid like ascites, peritoneal dilate, or efficient overflow can be misdiagnosed as peritoneum. Perinephric or pericardial fat, it looks like um, collection inside between, but it will not increase, and echogenicity is little bit different than the blood. Age artifact, as I said, it interface of the liver and the kidney. Sometimes it looks like collection between these two, but when you move the probe, it will disappear. A full stomach gastric content can mimic a perisplenic fluid collection, as you can see in this video. This is a patient with full stomach, and it looks like you can see the content of the stomach, and it looks like the fluid or content. This is a left upper quadrant view, and where you can see the stomach. So you have to be careful about it. Massive volume resuscitation sometimes lead to intravascular to intraperitoneal fluid transfusion, and which looks like hemoperitoneum. Again, injury related to free fluid, not hemoperitoneum, is like bladder injury, and it will lead to urine collection, or bowel injury may lead to bile collection or bowel contents. So you have to be careful. Ovarian cyst rupture or polycystic ovarian disease, there will be fluid collection, and it looks like hemoperitoneum. So in such cases, you have to be little careful. False negative can be seen in the obese patient, because it is difficult to get views. If examiner is inexperienced, there are chances of false negative. Early examination, immediately after injury, sometimes there is not huge hemoperitoneum, so you have to go for serial examination. And sometimes late examination will lead to clots of the blood, and which is difficult to detect, because it looks like the organs. So although serial fast examination can decrease the rate of false negative, when a clinical question is left unanswered by the fast exam, a CT scan is the gold standard for diagnosing the presence of free fluid in the source. So don't rule out CT scan always. So if once patient is stable, go for the CT scan for final diagnosis. Training and experience is important. 200 supervised examination must be performed to be considered as an experienced sonologist or experienced POCUS anesthetist or intensivist. During fast learning curve, the majority of errors occur in the first 10 examination. Usually it is like a gain setting or depth setting. Suppose when you shift from left upper quadrant view to pelvic view, you have to increase the depth, otherwise you will not see the structure properly. You have to adjust the gain also to see the structure. Thereafter, accuracy improves at the level of 25 to 50 examination. Once you go up to 50 examination, your accuracy will improve. Young et al. Determined that the false negative fast examination may result from the inadequate gain or depth setting and incomplete anatomic interrogation by emergency physician in training. So if you don't know anatomy, you will miss the things. If you don't know how to do machine setting or basics of ultrasound, you will miss the things. Future applications are there, like in triage for mass casualty, like in case of earthquake or in case of riots, you can use it in mass casualty to detect the things faster, because it is difficult to do CT scan for all the patients. Pre-hospital EFAST in ambulance and air ambulance will be uh, soon seen, but because of PCP and detect in our country, it is difficult. Wearable and portable telesonography robot will come, which will uh, continuously look for increase in hemoperitoneum or hemothorax to detect it early. In weightless situation, like in the space station, you can use this technique to detect the any injury. Contrast enhanced ultrasound for trauma will be coming soon, which will help us to detect the organ injury as well. So these are the future application which will be helpful in the future. Some clinical pain, pulse like depth and gain may need to be adjusted when transitioning from between the views. As I said, when you go from a upper quadrant view to pelvic view, you have to change it. Position can increase the sensitivity of the exam, particularly with Trendelenburg aiding the right upper quadrant and left upper quadrant view, and reverse Trendelenburg improving the pelvic views. Avoid bladder catheterization before obtaining the pelvic views with when clinically appropriate. If a single view is challenging, like left upper quadrant view, move on to another location to look for the fluid in the peritoneum. Fluid accumulation is a dynamic process. Serial examination can decrease the risk of false negative examination. So these are the clinical pulse which will improve your accuracy, which will improve your sensitivity in the fast examination. So this is all about it. Thank you. Thank you very much.